So our speaker today is Lucy Wang. She is a geriatric psychiatrist based at the Seattle VA, and she is also the program director for the Geriatric Psychiatry Fellowship with the University of Washington. She practices in the outpatient clinic at the Seattle VA, practicing geriatric psychiatry, and does a lot of dementia assessment at the VA. So she's going to talk to us today about dementia treatment principles as they apply to primary care. Thanks for coming.
Great, thanks for inviting me. Well, I appreciate the opportunity to just talk a little bit about dementia treatment. I've found over the years that my idea of what dementia treatment is just seems to expand and expand, because this is such a, even though it's one diagnosis, it affects multiple aspects of someone's life. So I've sort of put together this slide based on some principles that I've learned in training with some things that I've added on. I don't know if it got forwarded to you, but I also sent a reference that you could use, which was published by the APA not too long ago, that describes at least quality improvement types of measures that have been recommended to monitor as we're looking at improving dementia treatment in our practice and also amongst systems. So that is a nice handy reference from which I've added a few things to my slide set here. So the way I view dementia treatment is mainly through 4 categories. So if I'm working with a patient with whatever stage of say, Alzheimer's disease or dementia that they have, I will try to touch at least on one of these 4 categories pertinent to whatever they're dealing with at the time. So this is it. I look at the dementia process itself. I want to make sure that I'm covering my bases when it comes to the actual disease process and any medication or medical treatments that I might have available at the time, and also just make sure I'm monitoring how that dementia is at that stage or progressing, that type of thing. Dementia also affects or impacts someone's ability to communicate or experience medical illness, so it's important to assess medical comorbidities as well. The third bucket that I tend to look at, or I wouldn't say 10, I always look at because I'm a geriatric psychiatrist, are psychiatric symptoms, so screening for things like depression and other psychiatric symptoms and managing as I can. And of course, psychosocial issues is my 4th bucket, caregiver education, advanced care planning, safety concerns, things along those lines. So I'm going to go into each of these. I have a slide or 2 for each of these buckets, so I'll go on and discuss a little bit more in detail. Because this is an overview, I do leave a lot of stuff out, so if you do have any questions, don't hesitate, specific to anything I bring up. I'd be happy to take a break and try to answer those for you. So let's start with the dementia focus. So monitoring change, it is very important to keep tabs on how someone is doing and how they may be progressing. I'm presuming all of you are familiar with these, but I at least wanted to jot these down as a reminder. The MOCA is more commonly used these days because of the proprietary restrictions with the mini-mental state exam, but way back when I was in training, the mini-mental state exam was the way that we would assess how someone was doing cognitively. These are just brief screens that take 5 minutes in the office and can be very helpful, particularly people in the milder stages of disease, to assess progression over time. As people get more advanced, it may be harder to do these types of cognitive assessments, so I at some point transitioned to a functional assessment. You may or may not have heard of the FAST. It's easily found online. It's what we use at the VA to assess where someone is doing from a functional standpoint. Do they need help dressing? Do they need help with basic self-care? And it gives you a sense of whether someone's moving into what degree and from a functional rather necessarily a cognitive standpoint when testing gets to be more challenging. So I usually do one of those at each visit. And then we talk about what can we do to treat the dementia process itself. Just a quick reminder, there are a few FDA-approved treatments, mainly to try to handle the cognitive symptoms of Alzheimer's disease more commonly. So I've listed the cholinesterase inhibitors for you, donepezil, galantamine, rivastigmine. They are FDA approved for Alzheimer's disease of varying stages. Donepezil is FDA approved for all stages of Alzheimer's disease. Rivastigmine also is approved for Parkinson's disease dementia, which is interesting. I found these medications are reasonably well tolerated. The most common side effects, unfortunately, or I won't put this, the most common side effects that that I see are GI related, and when they do happen, they can result in impairment in someone's quality of life, so it's a common reason to discontinue. But diarrhea, low appetite, nausea, vomiting, those are the things that I find are limiting. And I also want to bring up Memantine real quick. This is an NMDA antagonist thought to reduce neurotoxic glutamatergic overstimulation or excitotoxicity. So it works quite differently from the cholinesterase inhibitors, but I feel clinically looks very similar in what you see as you in terms of outcomes and cognitive symptoms. It is FDA approved only for moderate severe Alzheimer's disease. I've seen a lot of people in the community prescribe this for milder stage disease. But technically speaking, there's a bigger bang for your buck when you're prescribing it in a later stage. I found that Memantine is relatively well tolerated with relatively few side effects. People often ask me kind of what are you looking for in terms of an outcome when you're treating with these medications. I extracted this from one of the early studies looking at donepezil. This particular graph shows the Mini-Mental State Exam score for people who are taking the drug at 5 and 10 milligram doses compared to placebo over the course of 24 weeks, and there was a separation by a couple of points. So it was found to be different, and that this improvement, or I wouldn't say improvement, this difference was lost after the drug was discontinued. I usually tell my patients when I'm starting these types of medications that they help the brain work as best as it can. It helps increase an availability of this certain neurotransmitter. It helps the neurons communicate more effectively, but unfortunately it doesn't stop or change the brain damage that's happening from Alzheimer's disease, for example. So this type of medication will help your brain, help you boost what you've got. So you've got sort of a temporary, maybe a little increase, or at least a temporary stabilization, but as the brain damage continues, you're going to still see the same decline and the same rate of decline that you would if you're taking placebo. So that's why a lot of people wonder, does this medication really work? Is it really helping? Because my loved one is still getting worse. Different people practice different ways, and I do know that guidelines for family practice are different for neurology and different from geriatric psychiatry. But the way I lean towards using these medications is if I start a medication and 6 months and a year later their MoCA is about the same, I'm going to assume that this person is probably getting that little bit of a boost, and as long as they're tolerating it okay, I'm going to say that person was a responder, and I'm going to continue it on forward. For some people, it's hard to know if it, I find it's difficult to predict whether you can or cannot stop it. I do have many colleagues who do find it's reasonable to stop a medication at a certain point in time. I tend to lean towards keeping a medication on board if I'm worried about if someone loses some aspect of functioning, how that will impact them. If someone's still living at home and staying at home is a priority, and they're in moderate stage, and if I lose even a little bit of functioning, like being able to help feed themselves, that type of thing, I may try to keep this on board just so I don't want to risk losing that type of functioning. Whereas if someone's in a skilled nursing facility with a lot of support, I may be more inclined to stop. So it really does vary depending on your practice and your patients or their family's priorities when it comes to medications. So that was box number 1, which is dementia. This is box number 2, which is medical comorbidities. Dementia is associated with increased rates of hospitalization. And there's been some work out of here, actually, that indicates some of these hospitalizations or these reasons for hospitalization could be avoidable with monitoring and education about symptoms. So these were the 4 that were highlighted in a paper that I can send to you later if you're interested. Actually, the reference, I apologize, is listed on the bottom there. Dehydration, CHF exacerbations, urinary tract infections, pneumonia. So it's helpful to inquire, also educate caregivers about symptoms that they may want to look for. Pain has also been recognized as frequently under-recognized in patients with dementia. Okay, here's my bucket number 3, psychiatric symptoms. This is my career, so it's hard to distill it down to 1 or 2 slides. But I'll just say a few things. One is that almost everyone has a psychiatric complication if they have a dementia. They're very common, they're broad ranging. They range anywhere from, and I've listed these are actually if there's an assessment tool out there called Neuropsychiatric Inventory, and there's an abbreviated version called the NPIQ that could be easier to use in the office if you're inclined to do that. It really lists 12 psychiatric symptoms that have been described and can be common in dementia, and a caregiver can just rate whether it's present and moderate, severe, and how frequent. And it really lists the gamut: agitation, delusions, depression, anxiety, irritability, nighttime behaviors. So just give you a sense, it really is a broad-ranging set of symptoms that someone can experience. And it is helpful to screen. I've found that many caregivers will just bring up maybe the most salient or important or pressing, but if you screen through them all, you actually realize people are more symptomatic than you're sort of letting on the office. Psychiatric symptoms, how to manage them, just some sort of general rules of thumb. All guidelines indicate that non-pharmacologic approaches to treating psychiatric symptoms are first line because medications do have significant side effects and can cause, it's just a tough balance between side effects versus benefit. So in terms of non-pharmacological approach, at least assess the circumstances and environment. There might be things that you, as just a person with common sense and experience, can help a caregiver problem solve a situation. Are there triggers in the environment? Are there things that you can add to the environment? For example, if someone doesn't have enough structure or doesn't have enough activity, can you add activity or refer someone to adult day health, that kind of thing, to help with a difficult behavior. So it's doing what you can from an environmental, certain sort of situational assessment. If medications are tried, it's another rule of thumb, and in geriatrics we always start low. But for mental health medications, we usually start at typically half the lowest adult dose and increase by small increments. Just keep in mind all psychiatric medications, all of them have side effects, and fall risk is listed even for SSRIs. So there's really no truly 100% benign psychiatric medication. Generally speaking, also what complicates, another complicating issue is that medications are generally not as effective with dementia compared to non-dementia related symptoms. For example, studies of depression related to dementia do show that patients do not respond as well to SSRIs compared to just younger people with just major depressive disorder. So it indicates that probably the pathophysiology or etiology behind, say, depression, even though it looks the same on the outside, the underlying pathology or pathophysiology is different and therefore may not respond to a medication approach quite as well. So in spite of that, it is still important work. These medications can still be helpful, but I really re-emphasize the importance of a combination or multifaceted treatment approach, including non-pharmacologic and pharmacologic interventions. My fourth bucket is psychosocial issues. Caregiver support is tremendous. I tend to refer to the Alzheimer's Association quite a bit. I give caregivers permission to take time for themselves. So resources including respite resources, paid caregivers, companions, adult day health, respite programs are things that I can often talk about or recommend. I also talk to patients eventually about considering the possibility that a structured living environment may actually decrease behaviors, I missed a word there, improve quality of life because staff may not be as burned out and there are more activities, a more structured structured environment that can help a little bit more than in say at home in some cases. Okay. Finally, in this fourth bucket, other things that you can think about talking about are healthcare planning, establishing a DPOA, living well pulsed, bring up estate planning, making sure people have good avenues of support, family and friends, even planning ahead. What if my loved one gets worse and who can I call to help, or do I want to start thinking about where I want to go if I need to move? So having those types of discussions are an important part of dementia care. Finally, I pulled off the Alzheimer's Association website, different psychosocial issues. I'm just going to list them all because I think you're all going to resonate. Fall risk, medication management, financial management, home safety risks, wandering, access to firearms, being left alone in home, inability to respond to emergencies. Driving is a big one. Operation of hazardous equipment, abuse or neglect. So these are all things that can come up. I don't have an easy answer for all of them, but I raise this as something that is important to keep in your mind as you're working with someone with dementia. So these were my 4 buckets. That was my brief overview, and I'm done. Do you have any questions?